I'm Elena Ratner. I'm the Division Director of Gynecology at Yale, and we are so thrilled to be with you tonight. And I'm joined by the most excellent providers, which I'm so proud to have as colleagues. Dr. Mitchell Clark, who is a gynecologist who is practicing currently at Waterford at Lawrence Memorial, and Johanna, who is the director and who runs multiple programs within our practice, most notably so that for early cancer detection called Discovery to Cure. And then Sexuality, Intimacy, and Menopause program, which is a survivorship program that we offer for patients with cancer that has to do specifically with menopause and with sexuality. So we are so excited to be with you today to share with you the updates in gynecology. So much has changed in the field of gynecology over the past decade. You know, we no longer treat the cancers the same. You know, we no longer treat the women the same way just because they have a certain kind of cancer. We truly now offer a personalized approach. Every woman's tumor gets studied and understood, and we truly offer a targeted, personalized approach, not to every cancer, but to every patient. We believe wholeheartedly in preventative medicine. Johanna will talk today about the role of genetics and the role of previvorship. You know, we have struggled over generations to find cure for ovarian cancer. Cure for ovarian cancer is very complex. There's a lot of chemotherapy resistance. There's a lot of reasons why, unfortunately, these cancers recur. And hence, we've concentrated for generations on early detection. And so much work and research is being done in early detection. But the future of ovarian cancer is probably not even early detection. The future, maybe even the present, is just prevention. Finding the women who are at higher risk for these cancers and then preventing cancers in them in the first place, so that early detection or cancer cure is not even an entity, that these cancers can be prevented before they even happen. So Dr. Clark today will share with us updates in gynecology, again, kind of concentrating on this kind of personalized approach that we offer very much within Lawrence Memorial and within the Yale Health System. And then Johanna will talk to you about previvorship and how important it is to find these women who are at higher risk for these cancers, and how important it is to really have comprehensive approach. You know, it is so important to remember that these genetic mutations do not just affect the ovary or the breast, that all of them are intertwined. And this is not just something that affects women. This is something that affects women and men for generations. And it is so important that we are offering this kind of a care to our patients and their families. So again, thank you and welcome. And we're so thrilled to be with you on this WebEx, but really even more so, we're so thrilled to be part of your community and to be providing gynecology care at Lawrence Memorial. Dr. Clark?
Yes, thank you so much. I'm just gonna switch over and share my screen with everyone. All right, so thank you so much, Dr. Ratner, for that excellent introduction, and thanks everyone for joining us tonight on this sort of rainy Wednesday evening. For those of you I haven't had a chance to meet yet, my name is Dr. Mitchell Clark. I'm within the Division of Gyn-Onc at Yale, and my clinical practice is focused here at Lawrence Memorial and at the Waterford Care Center. And we're going to start tonight's session by talking about updates in ovarian cancer, which, as Dr. Ratner has alluded to, is very exciting right now. I don't have any disclosures, either financial or use of any off-label medication in this talk. So just some objectives for what I hope to cover in a quick discussion on these highlights is talk a little about how the proposed origins of ovarian cancer have changed and how this impacts early prevention and early diagnosis, review some of the data on opportunistic salpingectomy and then risk-reducing surgery for our women who are identified as being at particularly high risk, And then in those women who do go on to develop a cancer, how we've increased our use of neoadjuvant chemotherapy and special interval surgical techniques for these women to help manage their advanced disease. And then probably most exciting of all is to discuss some of the emerging data on maintenance treatment, and so how we can extend the survival of our survivors of ovarian cancer for years down the road. So my practice is primarily focused here in the Waterford Care Center. Like I mentioned before, we see a full range of gynecologic malignancies, as well as complex GYN surgical care, as well as patients who are either thought to have or known to have a hereditary cancer syndrome, which Johanna will expand a little bit on later on this evening. This data is not new for many of you. Most of you are aware that this is the second most common gynecologic malignancy that we see in the US, but it certainly accounts for far more deaths. And unfortunately, in 2020, over 21,000 women were diagnosed with this disease, and 13,000 of them succumbed to their illness. And as we've alluded to, the problem for decades has been that most of these women present at a very advanced stage. And as we would expect with all cancers, our survival outcomes certainly decrease as stage increases. But we know now through advances in molecular testing and things that we'll talk about further on that these are not just all the same ovarian cancer. And this slide is very busy and there's no quiz at the end, but just to highlight the real heterogeneous grouping of histologic subtypes and how important it is that we expand our knowledge of how each of these relate to diagnosis and to treatment and to survivorship. This is a picture taken out of a book that many of us have probably seen in our training, highlighting the survivorship and lifetime experience of women with ovarian cancer. That really shows a sort of antiquated experience that many of us have been dealing with for years, which is survival measured in many months and not many years. And I hope we can circle back to this figure at the end of the talk and show how these advances in ovarian cancer have really led us to believe that we're going to pull this graph from side to side and really expand the survivorship time and disease-free time that our patients are able to experience. So what came first, the chicken or the egg? And where did this cancer come from? Some of you may have been aware of the data that is emerging to suggest that maybe the most common types of ovarian cancer actually started in the tube. For years, we thought that it was this ovulatory rupture on the surface of the ovary that was causing these mutations and a cancer would go on to develop. But now through some really exciting research and special pathology techniques, we're identifying these lesions at a very early stage, or what is called the stick lesion or the precursor lesion. And through this work and some very exciting science, we actually think that the most likely mechanism is that these cancers probably start in the tube and then migrate into the peritoneal cavity and spread in the way that we know ovarian cancer to behave. And so that brings up the opportunity of a salpingectomy for our women who are average age risk. And what is an opportunistic salpingectomy? When are these opportunities? If you're telling me the cancer is starting in the tube, well, let's take them out. So this can be at times when women are having hysterectomy for benign indications, women who are undergoing cesarean section who desire surgical sterilization, or perhaps women who are searching for surgical sterilization outside of pregnancy. I hear a lot of providers say to me, I've been doing one technique for years. I do the Pomeroy or the modified Pomeroy. I'm very happy with it. I'm very comfortable. Is the data strong? What is the benefit? And this just highlights some of the exciting research that's come out of some of the cancer registries showing a 35% risk reduction for death from ovarian cancer in women who underwent an opportunistic salpingectomy. I hear a lot of people say also, I'm a little worried at the time of C-section, those tubes are really engorged, or I'm worried about blood loss. But Jessica McAlpine, who was a fellow here at Yale a number of years ago and has gone on to Vancouver and done amazing research and work out there, showed that in her series, there was no increased blood transfusion, hospital length of admission was the same, and no readmission rates being higher for those who underwent this procedure, and really only added 10 to 15 minutes of additional surgical time. So, that's for our average age risk women, but as Johanna's going to talk about later, what do we do for our patients who are known to harbor a mutation in one of these genes that significantly increases their risk? And we've traditionally been doing risk-reducing bilateral salpingo-oophorectomy when women have made that decision after information and shared decision-making with their provider. But there are complications related to quality of life from surgical menopause. These are important decisions that women make, balancing their quality of life against the risk of cancer. And so 2 separate research groups have now collaborated to explore the idea of, well, if this is in the tube, why not just take out the tube? And so I want to caution you, this is still an ongoing clinical trial, but something I wanted to highlight as emerging evidence that's hopefully coming down the pipeline, the TUBA-WIST study, which is a combination of an American and a European initiative that looks at doing just the tubes and delaying the oophorectomy, so delaying that time. Again, we don't have the data yet for this, and we're hoping to see what emerges from this trial. But just to highlight the fact that we really are focused on trying to prevent this ovarian cancer before it even happens, and finding ways that we can do that balances quality of life and individual choices for women when they're trying to decide what to do for themselves. Unfortunately, a number of women will go on to develop an advanced ovarian cancer, and I'm sure, like many of you in your gyn-onc rotations as a resident, you were involved in these long, complex operations with lots of disease and really complex surgical debulking, because for decades our knowledge was that a big operation removing all the visible cancer as possible gives the best outcome to women. But I'm sure you also saw a lot of patients experience morbidity, some unfortunately mortality, and high complication rates for those who are universally treated with the same approach, so universally taken to the OR without consideration of individualized factors. And so there have been a number of trials exploring the use of, how about we give some chemotherapy first? Let's shrink this cancer down. Let's try to have an operation that maybe is a little less radical, but can still provide the same oncologic outcome for women. And this is just one of those trials that I wanted to highlight, which is the CHORUS trial. These folks randomized advanced stage ovarian cancer to undergo either upfront surgery followed by chemotherapy, or some chemotherapy first, followed by surgery, followed by more chemotherapy. And their results show essentially the same thing, that both arms of this study showed equal survival, both overall and progression-free survival. And we've now gone on to further analyze and try to identify for each individual woman who's best served by a primary surgery, who's best served by neoadjuvant chemotherapy, and really trying to make sure that we're picking the right thing for the right patient, and not treating this as just one lump category of disease. And with that has come the adoption of minimally invasive surgery for ovarian cancer. 10 years ago, this is something we would really have not even considered or thought about. But as we're treating more and more women with neoadjuvant chemotherapy, we're seeing more and more women who may be good candidates to undergo a minimally invasive approach. So what is the role of robotic surgery, minimally invasive surgery in this disease? For women who are not able to undergo that primary debulking surgery due to individualized factors, there may be an opportunity to offer them a surgery with all the benefits of laparoscopy while still maintaining the same oncologic outcomes. And so we're very excited to see the development of randomized control trials that are going to answer this question. These are ongoing, but until then, we continue to look for patients who are excellent candidates who may be able to benefit from a minimally invasive approach when carefully selected. One additional exciting advance in the way we do these interval surgeries is the incorporation of what is called heated or hyperthermic intraperitoneal chemotherapy. For those of you who've taken care of patients with appendiceal cancers or some of the other GI cancers, you may be aware of this technique for those diseases. But we've seen randomized evidence to show that in women who are carefully selected and offered this as part of their treatment, they actually experience an improvement in their survival as well. Again, this is all about making the right selection for the right patient, taking into account all those individualized factors. This is not a one solution for every woman type of disease anymore. And just to finish off with what I think is probably some of the more exciting evidence, and that will sort of loop us into Johanna's discussion very nicely, is really the role of maintenance therapy and how our understanding of the biology of the tumor is critical in assessing individualized treatment as patients complete their chemotherapy. We know that unfortunately, most of our patients with advanced stage disease will experience a recurrence at some point in their cancer journey. So how can we extend that time between recurrences while maintaining excellent quality of life? I'm not going to get too much into the sort of molecular biology here, but there are some very exciting studies showing that almost half of ovarian cancers are deficient in mechanisms that allow for DNA repair. And without taking us all back to our undergraduate molecular biology course, really to just summarize that we're really exploiting the inherent problems with these cancer cells and turning them on themselves. And so through some very exciting preclinical and clinical trials, we've seen that these class of medications called PARP inhibitors, which are an oral drug taken for 2 to 3 years after chemotherapy, have had excellent results in allowing patients to experience a prolonged survival. SOLO-1, which was just published a couple of years ago, was probably the most exciting of these trials. These were women exclusively with the BRCA1 and BRCA2 mutation, either in their tumor or in all of their cancer or all their cells, or the germ line. And when given for 2 years after they completed their treatment, they had significantly longer progression-free survival than those women who went on to take placebo. And this is hot off the press from the SGO meeting about 10 days ago. Really thrilling results to see the 5-year updates of this trial. And these are just numbers we never dreamed of seeing in ovarian cancer, with patients who are randomized to olaparib having a median progression-free survival of almost 5 years. And if we just think about the women we've cared for over the years with ovarian cancer, to imagine telling someone after their initial treatment to expect a 5-year progression-free survival, that's just really thrilling stuff that we could have never imagined in the past. There's still a role for these types of medications in women who are not BRCA carriers, which is why we are very diligent about testing tumors and understanding the unique characteristics of every woman's ovarian cancer. There's data to support the use of these drugs in all comers with ovarian cancer, but the strength of those recommendations and the data is certainly less for those women who don't have these inherent mutations or changes in their tumor DNA. So we take the time to really explore that so we can offer women as much education and data so they can make a decision about how they want to manage their care. So just to circle back to that figure that we talked about in the beginning, and to just highlight some of the things we've talked about tonight and how we're trying to pull this graph from side to side and extend the survival, we hope through perhaps one day being able to do salpingectomy or to continue doing BSO now, we're able to prevent ovarian cancers from developing. We're able to improve the treatment of women when they are diagnosed with their disease. And through PARP inhibition, we hope to extend that survival for women for many, many years to come. And so there's still a lot of exciting work going on. And I hope we can come back to you next year with an update that just shows that we're measuring the survival in many years. And so with that, I thank you so much for listening, and we'll hand things over to Johanna. If there are any questions right now, we can take them. Otherwise, we're going to have a great Q&A session at the end. So I don't think we have any questions. So Johanna, maybe you want to lead us in?
Sure, yeah. Let me just share my slides here. Thank you so much, Dr. Clark, for the opportunity and for inviting me to join you guys tonight. And Dr. Ratner, thank you for the nice opening welcome. And so I will certainly try to keep my talk to 15 minutes, but if there are any questions at all during the presentation, there is a Q&A section at the bottom of your screen, and you can type in a question and we will get to it either during the presentation or after. So I wanted to talk a little bit more about genetics in GYN oncology, and my name is Johanna. I am a physician assistant trained at Quinnipiac University. I graduated in 2008, and I've been part of the practice at Yale for about 3 years now. So I'm thrilled to share some information with you. I have no disclosures tonight. So we're learning more and more about the genetics of gynecologic cancers. And so of course, for probably about 20 to 25 years now, we've known about the BRCA1 and BRCA2 genes, but we're finding out about the additional genes that are implicated in gynecologic cancers PALB2, BRIP1, the RAD51 genes, and some other ones. So these mostly lead to increased risk of breast, ovarian, fallopian tube, and peritoneal cancer, as well as possibly pancreatic and prostate cancer, and in BRCA2 specifically, a risk of melanoma. You may know about the Lynch syndrome genes or the DNA mismatch repair genes that can lead to multiple cancers. We often think about the GI cancers like bowel or colorectal cancers, but also endometrial ovarian cancers. Some of the less common genetic syndromes that we learn about are Li-Fraumeni syndrome or TP53 mutations, Cowden syndrome or PTEN, and Peutz-Jeghers syndrome, which is the STK11 or LKB1 gene. So these can have multiple different types of cancer and even benign tumors that affect women with Peutz-Jeghers syndrome. When we think about the inherited breast and ovarian cancer syndromes, we think about 15 to 20% of ovarian cancers being caused by a BRCA or similar mutation. And about the same for breast cancer. One of the differences is that breast cancer also can have more familial clustering, where you can see these families with multiple cases of breast cancer, but may not have a specific gene identified. And we can also see that in ovarian cancer as well. We do see women who have a couple different family members with ovarian cancer, but no gene identified yet. So there's probably still more down the road that we'll learn about with time. The risks, this is probably a little outdated now. This is from 2018, but we're learning more each year. The risk with BRCA1 and BRCA2 in regards to ovarian cancers is about 40 to 50% risk, but lots of different numbers that we see for BRCA1 and for BRCA2, a little bit lower risk and also a little bit later in life than the BRCA1 risk for ovarian cancer. I'm actually going to skip this slide. So it's really important to test for the BRCA mutations in any woman with an ovarian cancer, especially high-grade serous ovarian cancer. But really now the recommendation is any ovarian cancer type should have genetic counseling and offer genetic testing, not only because it can help the patients in regards to knowing their prognosis, knowing their decisions, for example, as Dr. Clark mentioned, the PARP inhibitors, and also being able to put the patient into long-term remission. And at that point, we sometimes now are preventing other cancers. So we do have ovarian cancer survivors who are doing well from their disease and are now having a risk-reducing mastectomy to prevent breast cancer as well. Of course, it's important for the relatives to know as well, so that if there is a mutation in the patient's DNA, then they can have cascade testing in the rest of the family members, and who can also have risk-reducing or prevention strategies. So again, the most common thing that we like to talk about is hereditary breast, ovarian, and pancreatic cancer, specifically the BRCA1 and 2 genetic mutations. More common than we used to think. So depending on the source, we're now learning that there is a BRCA mutation present in about 1 in 200 people in general. And in the Ashkenazi Jewish population, about 1 in 20 people may carry a mutation in BRCA1 or BRCA2. So really, really not as rare as we used to think. Recommendation again from the Cancer Network and the Society of GYN Oncology is for universal genetic counseling and testing for anyone with ovarian cancer. Another important thing to remember is that they're not the same. So BRCA1 is not treated, or prevention is not the same as the BRCA2 patient. So we have to take that into consideration. Lynch syndrome is the same. There are different genes and they're not all the same. So we need to make sure that we're not treating each Lynch syndrome patient equally. And I'll show you a nice sample of that on the next slide. Genetic testing is recommended for women with an endometrial cancer or a colorectal cancer as well, men and women with colorectal cancer who have evidence of what's called microsatellite instability, or a loss of DNA mismatch repair proteins on immunohistochemistry. So this is where now every colon cancer and every endometrial cancer is getting this special testing, the microsatellite testing, the IHC. And if it's identified that they have an issue, they will then go for genetic testing and counseling to see if they carry a germline Lynch syndrome mutation. So the National Comprehensive Cancer Network has really nice tables and guidelines for the prevention of cancer and the risks of cancer in both the BRCA mutations and the other mutations as well for HBOC syndrome, but also for Lynch syndrome. So I'm just giving you one example of the MLH1, which is the one of the more common Lynch syndrome genes. And it gives you specific cancer risks, or at least ranges of risk, compared to general population for each of the associated cancers. And what's really important to know is that MLH1 has a higher risk of many cancers than, for example, PMS2. So it's not just Lynch syndrome as one size fits all. So what are the guidelines for identifying who should be screened for genetic cancer syndromes? Well, I'm just going to go over briefly in the next 10 minutes or so the guidelines from ACOG, the National Comprehensive Cancer Network, the USPSTF, and Society of GYN Oncology. In a committee opinion piece from 2011, there were just very general guidelines that women should have family history evaluation as a screening tool, should be reviewed and updated regularly, and when appropriate, further evaluation should be considered and referral to genetics as needed. That was updated with a lot more information in 2019. So this is kind of talking about every patient in your practice in general OBGYN should have a hereditary risk assessment, taking a good family history, and if there's suggested that there's an increased risk of a hereditary syndrome, referring to a specialist, or if you have the expertise in genetics, then, or someone in your practice, for example, a practice nurse, can give that counseling and make an educated decision about genetic testing for the patient or the appropriate family member. We are now doing more multi-gene testing. So this is panel testing as opposed to just the BRCA1 and BRCA2 test. It's much more affordable than it used to be, and the tests are better than they used to be. So we also recommend that people who had genetic testing before about 2012 be offered updated panel testing to make sure that we didn't miss anything back then. Another guideline talks about the importance of pre-test and post-test counseling. So I know these are busy slides, but talking about what it means to have genetic testing, what the result might be, and what it might mean for their family, for themselves, for their medical insurance and life insurance, and how to communicate those results to the patient and counsel them after the test results are back. If there is a clinically significant mutation, patients should really be encouraged to share the results with their family members and recommend that the family members also be tested. And that can be really hard to manage. So the question is, am I then as the provider responsible for the family members? And that's sometimes where a genetic counselor can really help you by drafting a letter. The patient can give the letter to their family members and they can help share the information for how everybody in the family can get tested. The USPSTF recommendations were updated about 1.5 years ago, and this was in 2019. And one of the biggest changes to this was when collecting a family history to also collect information about any Ashkenazi Jewish ancestry. So really that should be one of your questions on the screening for family history. Do you have any family history of cancer? What types of cancer, what relatives, and is there any Jewish ancestry in your family? So that's one of the biggest updates in the guidelines. Again, it's talking about integrating services, individualizing your questions, and plan for genetic testing for your patients to optimize the benefit and minimize the harm. So the USPSTF report was published in JAMA about 1.5 years ago, again, talking about identifying appropriate candidates for genetic testing and then what type of tests to order. So there's lots of different steps in the process about what are the harms of asking, what are the harms of testing, what are the harms of intervention after we test. I do see a question in the Q&A that we'll try to get to shortly. So the USPSTF recommendation does give a B recommendation that primary care clinicians, including OBGYNs, assess women with a personal or family history of breast, ovarian, tubal, or peritoneal cancers who have any ancestry associated with BRCA mutations with an appropriate risk tool, and they do give some options for different tools to use. And if there's a positive result on the tool, they should receive genetic counseling and potentially genetic testing if they're interested. They do not recommend counseling for women whose ancestry is not associated with a potential mutation. So we're not sending every woman for genetic testing. One of the examples is a 7-question family history screening. Others include an Ontario family history assessment, Manchester scoring system, the referral screening tool, a pedigree assessment tool, and the Tyrer-Cuzick model, which is good for breast cancer risk. So these are just short screening models that can be used in your practice for regular annual visits. Shifting gears to the SGO. SGO again recommends genetic counseling and testing for women who are at risk of having a hereditary breast and ovarian cancer syndrome. They are recommending more and more now to, again, have somebody help you with that, or as a primary provider to have the expertise. And I'll show you some ways that we can gain that expertise to provide genetic counseling for our patients. It is always important to have experts available after tests to help, interpret the test and recommend the treatment plan. It's important to have an interdisciplinary team, and I'll show you who the team members might be for somebody who has a hereditary cancer risk. This talks about a woman's personal cancer history and the family cancer history, and who should be offered genetic counseling and testing. So there's anybody with a high-grade ovarian cancer, a breast cancer early in life, premenopausal, women who have a limited family history or the family history is unknown, women who have a pancreatic cancer family history or prostate cancer, women who have a triple negative breast cancer, women who have breast cancer with Ashkenazi Jewish ancestry, etc. And then there may also be situations where you'd want to refer for genetic counseling, even if you don't know the family history. So for example, if someone has very few female relatives, many relatives had hysterectomy at a young age for unknown reasons, or there's adoption in the lineage and you may not know. Also for Lynch syndrome, again, mutations, anyone with an endometrial or colorectal cancer who has the mismatch repair genes or microsatellite instability, or again, depending on the family history of colorectal or other gynecologic cancers. If you don't have access to the NCCN guidelines, I would certainly encourage you to sign up. It's a free membership for NCCN to access the guidelines for prevention and cancer risk reduction. And a couple years ago now, this was changed from breast and ovarian cancer now to breast, ovarian, and pancreatic cancer syndrome. So pancreatic cancer is becoming more recognized as part of this cancer history syndrome, and pancreatic cancer is now an indication for genetic counseling and testing, as well as any first-degree relative of a pancreatic cancer patient should have genetic testing if that person is no longer living. So NCCN recommends that pre-test counseling be done prior to testing, consideration of the most appropriate test to order, and then post-test counseling when the results are disclosed. So then anybody who, again, has that experience and expertise in cancer genetics should be involved at each stage. And so there's some good algorithms to help with how we do this, how we help the family, and what the outcomes might mean for our patients. The NCCN also has some really nice tables about what the cancer risks are and what the recommendations are. So this is just one page of the guidelines, but there are actually 3 pages that include each of the different mutations that your patient might carry. And of course, they're not all treated the same. So for example, we've seen patients in our office who understood or heard that he or she carries a mutation in the BRCA gene. And they come to us saying, I have the Angelina Jolie gene. And then we find out that on their genetic testing, they actually carry BRIP1, which has a much lower risk and is managed very differently than BRCA. So it's important for us. We like to see the patient's genetic testing results with our very own eyes before we start to make management recommendations. So just to kind of move on here, this is what's really important for our patients. It is a long process. We need to first identify the risk, give some counseling, identify who the best person in the family would be for genetic testing, have that person tested, do the post-test counseling. So what does it mean if it's a positive or negative test result? Offer testing for the rest of the family members. That's called cascade testing. Provide emotional support, and that really is part of the entire process, not just a single step in the process. We have to emotionally support our patients with this complex decision making. Refer as appropriate for breast surveillance, on gynecologic surveillance, pancreatic surveillance, skin exams, all the different referrals that are necessary. Support them in fertility decisions about their children if they're young, and then provide the cancer surveillance and cancer prevention if we can. So it is a lot of work. There are a lot of questions that we can ask ourselves. Do I have time to collect a full family pedigree? Do I remember how to do that? Does the patient know their family history, or do we need to go back and gather more information from other family members? How do I know what test to order? Does my patient, have the emotional readiness for the testing? Will they be okay with the result? Do they want to be tested, or do they not want to know their genetics? Should I recommend, or if my patient asks about things like 23andMe or the direct to consumer testing, do I know how to help him or her interpret that test? Who is the right person to be tested? Am I ordering the right test? Am I ordering from the right company? What does the test mean? This is not just positive or negative anymore. It's now likely pathogenic, likely benign or benign. And then in the middle, there's this variant where we know there's a change in the gene, but we don't know if it's necessarily cancer causing. How do we proceed with the family members? Do I have to follow up all the family members testing? And how does it affect my patient as far as insurability and general health? So there's a lot of things that we may not know how to help our patient with, and we need to know where to refer them to if needed. This is what I was talking about with the different test results that can occur on testing. And if you've ever come into, finding a test result or coming into a conundrum where you didn't know the answer, you're not alone. And there's actually a series of articles from some of our Yale genetic counseling colleagues, Karina Byerly, who was one of our genetic counselors, Danielle Bonadies, Danielle Campfield was her maiden name, who was one of our genetic counselors who's no longer at Yale, but has done some great work in talking about the errors that can happen. The wrong test is ordered, the test result is misinterpreted, or there's not enough patient follow-up. So it happens. It's not uncommon for the test to be interpreted incorrectly. And that's where our genetic counseling colleagues can really help us. It certainly takes a village to support these patients. So whether your patient has a mutation or has a family history, first of all, she's probably seen cancer, and she's probably experienced a loved one who's been diagnosed and treated for cancer, and there's trauma involved in that. The patient probably has a lot of questions and concerns about her family, her children, what it means for her health. And so it takes a lot of people to really help support this patient in making sure she gets the best care. Smilow has some great resources, the Cancer Genetics and Prevention Program, which is available also by telemedicine these days. There's a lot of resources from ACOG that are available online. Jackson Laboratory up at UConn has some modules that I'll show you shortly. SGO has some information, and there is, if you're really interested, a certificate program that's online in clinical genetics and genomics. And this program is actually for physicians or nurses or PAs, APRNs who are interested in learning more about genetics and want to, help advance their care. And it's a one-year online program. The Jackson Laboratory Genetics modules are great because they're 15 minutes, case-based, and they do give you CME credits. So those are available at Jackson Lab, which is part of UConn. And there are 11 cases in that in those modules. And the Society of GYN Oncology also has a genetics toolkit that has 7 case-based modules that's available for providers online. Yale's Cancer Genetics and Prevention Program is at the St. Raphael campus in New Haven. It's co-directed by Dr. Hofstetter and Dr. Yor, who manage breast and GI oncology. Dr. Bale is the genetic scientific director, and there are many great genetic counselors available to answer any questions that we have. And of course, Dr. Ratner and myself are there to support women, and Dr. Farrell helps with pancreatic cancer surveillance. Genetics can be referred through HIPEC or by calling 201 DNA. And with that, I will stop and take questions, or we can move on to the next presentation. Please feel free to contact us anytime. You can email, call me, and we're happy to help see patients or help with answering any questions or getting you to the right people. So thank you so much. I will hand it back over to Dr. Clark, and we can take questions if we need to.
Thanks, Johanna. I think this is a great question by Kim. Thanks, Kim, for sharing your personal experience with the meeting. And maybe I'll just read out Kim's comment / question, and maybe you can give us a little bit of guidance from your perspective, Johanna. So Kim writes to us to say that it was recommended to me when I received a breast cancer diagnosis and prior to genetic testing to go ahead and secure life insurance. If a mutation is identified, it can make it difficult and or impossible to get coverage. I thought this was a great idea and share that with my patients now. So what's your experience, or is this a question that you get from patients who come through the genetics program that you oversee, Joan?
We absolutely do. And so if you haven't learned about it, there's something called the Genetic Information Non-Discrimination Act, or GINA. And GINA prevents people with a genetic predisposition to cancer from being denied a job or health insurance. Unfortunately, GINA does not protect people from being denied life insurance coverage. So life insurance certainly is something to consider before people undergo genetic testing, if that's important to you. And the genetic counselors are pretty good at talking about that as well. But for health insurance and for employment, there is some legal protection from discrimination for people who have a predisposition to cancer.
That's great. Thank you. All right, so we'll just move on to our final session for the evening. We're going to switch gears a little bit away from ovarian cancer and genetics and how that relates to gynecologic cancers, and talk a little bit about cervical cancer, both prevention and detection. I think we have a great group tonight that ranges from gynecologists to those who do a lot more primary care. So I thought this would be a relevant discussion to talk about a little bit of the updates from the ASCCP. We'll talk a little bit about HPV vaccination and understanding the role of HPV. And so I'm just going to switch over my slides here. Okay, great. And it's the same me talking. We're just going to shuffle over to cervical cancer prevention. So we're going to review a little bit the WHO global strategy to eliminate cervical cancer, which has been recently put forward and discussed heavily at the recent SGO meeting, as this is a priority for the WHO. But then loop that back to how does that affect us here at home in Connecticut and the United States? We'll talk quite extensively about the data on HPV vaccination, as well as the indications and how that has evolved over time. And then learn to apply techniques for how we can improve our vaccination rates here at home, specifically related to what we're kind of coining the Catch Up Cohort. And then we'll segue into a little bit of a discussion on the updated 2019 ASCCP guidelines and how the newly developed app that can be downloaded from the Android or iTunes store can really help you guide your decision-making and provide women the most individualized risk assessment when trying to decide how to manage abnormal cytology or biopsy results. I don't have any financial disclosures. We're not talking about anything off-label, but I do want to just acknowledge and thank Merck for providing some of the infographics and informatics on HPV data as it relates to cervical and head and neck cancer that we're going to talk extensively about today. So again, I think this is all very familiar information, but worthwhile to remember that cervical cancer is really a global burden. It's the fourth most common cause of cancer in women worldwide. And in 2018, over 500,000 women were diagnosed with this disease, and over 300,000 of women died. Almost all cervical cancers are related to an HPV infection. And what we see here on the top is a figure that highlights the incidence of cervical cancer worldwide. where we see a disproportionate burden in African countries, as well as certain South American countries. And then when we juxtapose that against the bottom image showing the implementation of publicly funded HPV vaccine programs, we really see how HPV vaccination and prevention through primary prevention methods has been effective, and it's just unfortunately not available in the regions of the world where this disease is as prevalent as it is here. The WHO is really taking a multi-pronged public health approach to try to reduce the burden of cervical cancer worldwide. And the best way to do that is through prevention, primary prevention through vaccination efforts. And I'm not going to go into all of the details of their plan, but what I do want to highlight is that, you know, as much as we talk about this as a global problem, we really have an opportunity for improvement closer to home. And this is the CDC data on vaccination rates as of 2018 for HPV vaccine. And we see that for girls aged 13 to 17 and boys aged 13 to 17, our rates of vaccination were approximately 50%. And that's pretty low. When we compare that to other vaccines given in the same age category, so we think meningococcal, which has a 90 to 95% vaccination uptake rate, there really is an opportunity to improve here. And I hope at the end of this, we'll have highlighted some techniques and ways that you can improve that in your own practice. These are just want to go through sort of the impact of HPV. And again, I want to thank Merck for providing some of this these graphics, which really depict the burden that HPV has on the lower genital tract and head and neck disease. There are over 14 million new HPV infections yearly, and almost half of these are in people aged 15 to 24. These HPV infections will go on to account for anogenital diseases, including cervical, vulvar, and vaginal cancer, but also a high number of anal cancers as well that will affect both men and women. And I think that should really be a theme throughout, is really the impact that is also happening on men, especially for our audience who may have a practice where they see both men and women. But is there efficacy in this vaccine, and how, what does the data show in terms of the prevention of these cancers? And we see that in people aged 16 to 23 in multiple studies, those cancers that were HPV related specifically, there was significant efficacy in reducing the burden of HPV related malignancies, as well as genital warts, which are a significant burden on both our patients, but also on our healthcare system. And millions of dollars are spent annually on managing these diseases that are really preventable through primary prevention. So what are the indications according to the FDA? And as of right now, it is indicated for girls and women 9 through 45, and we'll talk about that expansion to 45, for the prevention of the following diseases. So this is cervical, vulvar, vaginal, anal, oropharyngeal, and other head and neck cancers related to HPV, as well as the benign but bothersome genital warts that are caused by the 6 and 11 subtype, as well as prevention of the pre-invasive diseases of the lower genital tract. There's a very similar recommendation for boys, however, obviously no CIN, BIN vein, but otherwise a very similar recommendation and indication there. So where does the data come that helps us guide our decision-making regarding the expansion of the vaccine towards people who are 24 to 45? And so in this study, and this is a sort of end of study follow-up paper, looking at this age group specifically in women, and they use the quadrivalent vaccine, and we have no reason to believe that the efficacy will not be as good in the non-valent vaccine, Gardasil 9. They looked at a number of outcomes related to HPV infection. And here in the per protocol, and I emphasize that because the intention to treat is a little bit different, we look at the observed efficacy of the vaccine in preventing a number of different outcomes. And when we look at overall persistent infection, or CIN, or other diseases of the lower genital tract, the efficacy was about 88%, a little better in those who were younger and a little less in those who were older. However, the impact on CIN 2 or 3 or worse, although listed as 83, unfortunately, those confidence intervals do cross 1. And so the impact there may not be as strong. However, you know, I've had many patients who come into my office who have a lot of questions about this, and they fit in that age category. And we'll talk about how to address that on a very individualized, individual risk assessment so that we can help women make informed decisions with the data that we have. So currently the CDC recommends that as of 2019, harmonization of catch-up vaccination for appropriate persons through age 26 should be undertaken. And that group from 27 on to 45 is really shared clinical decision-making. So I saw a young woman recently in my practice who has been in a monogamous relationship since her first sexual encounter. She's now 28, 29 years old. Unfortunately, she's gone through a divorce and is re-entering the dating and had questions about the efficacy of this. And so we talked about that, and through shared clinical decision-making, she decided to proceed with getting the vaccination. Now, that's not to say that that is going to provide her the same efficacy as someone with a younger age category of the FDA recommendations, but she still falls within the CDC and the FDA recommendations. And I would encourage you to have those conversations with patients on a very individualized level. And so there are a number of women nationwide who still could benefit from updating their vaccination status through this catch-up cohort. And even more importantly, are a number of men. And so for those of you who also take care of men in your primary care practice, I would encourage you to consider this and when speaking with them about their overall primary prevention. We can't go through a talk in this time period without discussing safety of vaccine. It's on everybody's mind with the COVID vaccine, but just to highlight that this was a very safe vaccine with very minimal side effects and low-grade toxicities. So what can we do to increase vaccination rates here in Connecticut to try to prevent all of these HPV-related infections and, more importantly, these HPV-related malignancies? And we want to assess the immunization status of our patients at each clinical encounter. And then what I think is probably the most important is the recommendation of the provider. And patients very much rely on your opinion and value your input into their decision-making. And so by educating yourself about this data and these recommendations, you'll be able to provide a strong recommendation if it's appropriate for that patient. We want to either administer within our own practices or refer on to either a pharmacy or a clinic that can provide vaccination, and to ensure that our vaccination status is updated and documented for all of our patients. These measures are supported by ACOG and encouraged. And there are a number of opportunities that you can look at in the evolution of their relationship with your patients, beginning as when they transition from care from the pediatrician's office into gynecologic care. And so perhaps they were not offered or did not accept vaccination in that earlier cohort, the nine years and up. And so this transition into care in your GYN practice is an opportunity to readdress the data and discuss that opportunity with patients. When we're giving other vaccines, it brings up another opportunity to discuss the increased use of HPV vaccination. And we talked before a little bit about how meningococcal vaccine given at a very similar age has very high rates of uptake, but we do not see that same experience with HPV. And so by including HPV vaccination in the discussion at the same time will provide an opportunity, hopefully, to see increased rates of vaccination. As people are heading off to college, this provides another opportunity for counseling, either in combination with other counseling efforts regarding perhaps birth control or pap smears. But this is another opportunity where you may be able to provide an opportunity for a man or a woman to become vaccinated prior to heading off to college. And like I said before, the greatest predictor, and this is shown out in a lot of studies, is really the recommendation of the healthcare provider. And so take that to heart, and patients really value that when trying to make a decision on what to do. I'm definitely not an otolaryngologist or an ENT surgeon, but I want to highlight how we're really trying to expand the messaging around vaccination to not just be related to cervical cancer, but the burden that HPV has on a number of other head and neck cancers, and to frame our discussions more around HPV vaccination as a way to hopefully prevent a malignancy, and less around the HPV infection itself and the stigmas that may be associated with that for one reason or another. We see that there is a relationship between HPV and cancers of the head and neck. And we see that the prevalence of different HPV types is very similar to what we see in our cervical cancer patients. Very interestingly, we've seen a decline of cervical cancer over the years, but are beginning to see an increased rate of oropharyngeal cancer, especially among men. And there are significantly more oropharyngeal cancers diagnosed annually, which just brings even more importance to why we need to include that as part of our counseling and when we're discussing the benefits that we can expect from HPV vaccination. Males are affected 5 times more than females when it comes to these types of cancers. And so it really behooves us to discuss these benefits at every clinical encounter. So if you're caring for a mother who has a male child who is perhaps of the age that he could benefit from HPV vaccination, that's an important discussion that you can have as the primary care provider of the mother, the grandmother, whoever it is. And the more that we move this conversation towards HPV as an infection and HPV vaccination as a cancer prevention strategy, we hope to see increased rates of vaccination. And again, I think, I can't phrase it any other way than just we have to try to, provide our patients with all of the data and all of the information on the potential benefits of this cancer prevention strategy, and hope that through that we can remove some of the stigma associated with HPV vaccination, and highlight the importance for both men and for women. So with that in mind, and having talked on and on about the importance of HPV and how it relates to cervical cancer, I do want to talk a little bit about the updated ASCCP management guidelines and how they're really well summarized in what I think is a pretty easy to use app that you may consider incorporating into your practice and as a way to help risk stratify and provide patients with the most up-to-date information on the risk of cervical cancer. And so this app reflects the 2019 updated guidelines. And one of the greatest shifts is it really highlights the incorporation and the importance of test history into calculating risk. So you'll see, and we'll provide an example tonight of how it looks, but it's not just about that one single smear as a snapshot in time. The data is really supporting the use of understanding a woman's history of dysplasia and history of HPV infection in order to really understand what is her individualized risk assessment. And so we've known for a number of years now that HPV-based testing strategies are certainly superior to cytology alone. This is really a sentinel paper that highlighted that, showing that on the bottom here, we can see HPV and HPV co-testing in the incidence of CIN, predictive of the incidence of CIN3 or above. And the PAP history as well really matters. This is a paper currently in press and highlighted at the recent SGO meeting, just highlighting the real importance in understanding the multiple prior screening events that a woman has undergone and trying to assess her individualized risk. And that's what this app really provides. It's a chance to individualize someone's risk assessment so they can make appropriate decisions for themselves. And so we see here on the left that a woman with 3 negative co-tests really has a near negligible risk of a CIN3 or above, whereas someone who is HPV positive or persistently HPV positive or has had treatment for a CIN3 or above lesion is certainly at higher risk than her well-tested and co-test negative counterpart. And so this is reflected in the app, and those of you who have used it or reviewed the guidelines can appreciate the sort of differences in the recommendations and how things are looking compared to before. But it's really all about risk assessment as opposed to direct indications and recommendations on what to do next for treatment or testing. So this is just a little example of how the app looks. So on the left-hand panel, we selected perhaps a woman who is 25 to 29, although not a great example because we should probably be focused on 30 to 65 if we're looking at the importance of HPV. And then we select that, and then we go down to indicate that we're interested in the management of routine screening results. And then we are able to select all of these different all these different variables that will go into helping predict risk. And what's new and important is the question of whether or not patient has previous screening results that can be inputted into this algorithm to help us understand what to do next. And so our patient, yes, she has been compliant with her screening, and so we have entered her previous screening history. And so we go on now to include those prior test results, and our recommendation based on what we've entered is for a 1-year follow-up. But what's nice, and I think is really helpful for patients and ourselves to understand the overall risk, is this second image, which is the risk of CIN3 or above. And with that, we're able to appropriately triage her to next steps. So just to summarize, we've covered a lot, but I think really it's important to consider education and counseling on the benefits of vaccination at each clinical encounter, as well as to stress the importance of a strong recommendation for those who are eligible. Really to emphasize the importance of this intervention as a cancer prevention strategy, and to identify someone within your practice or your community practice who can really champion this effort, and then routinely reassess your strategies and look for areas to improve effectiveness. And I would encourage you to consider this app as one tool that you use in helping manage cervical cancer screening in your practice. So with that, thank you so much. We're going to stop the share and open it up for questions, either regarding our cervical cancer talk or anything that we've covered otherwise this evening, and hope we can clarify any points or answer any questions. I don't see anything in the chat right now, but we'll give it a couple more minutes. Again, if you have any questions, I didn't put my email address out there, but please feel free to reach out to me directly. It's my name, mitchell.clark@yale.edu, and I'd be happy to help answer any questions or help you navigate a referral process if you're seeking to refer your patient to the Smilow Center for evaluation. And I don't see anything else, unless Johanna, you have anything to add or?
Yeah, Dr. Clark, thank you. I just wanted to give a shout out to a couple of our patients. I recognize some of our patients that are on tonight as well. And thank you for just being women who have been champions in our program and just are getting the word out there that we can, detect cancer earlier. We can, take really good care of you, and we want you to be part of our family. So for the women who are out there that are our patients, thank you for joining in. For people who don't know yet, we have something called Discovery to Cure, which is one of our programs that focuses on prevention. And we do have a website. We have a something called the Teal Times, which is one of our newsletters that can go out to providers or women and patients. So if you have any interest in getting connected with us, I'm happy to help connect you.
Great. Yeah, and I agree. I really thank our patients for advocating for themselves and for others in the community who aren't aware of the resources that are out there. And I think all of us, I'm going to speak for Johanna, but it's really our patients who motivate us and their journey and their strength that is so motivating for us to do what we do. And it's such an honor to take care of these strong women who really are paving the way for future treatments through participation in clinical trials and things like that. So we have one question here from someone in the audience asking about any known connection between vulvar cancer in BRCA2 patients over 75. Typically, the older women with vulvar cancer is typically related to the lichenoid diseases, less related to the HPV infections. And Johanna, I don't think any strong association known between hereditary breast ovarian cancer genes or the HR genes and vulvar cancer.
No, as far as we know, there's no association with vulvar or vaginal cancers with genetics. The only thing that may cause cervical cancer is one of the rarer gene mutations. But when we think about hereditary breast and ovarian cancer syndrome or Lynch syndrome, we're thinking ovarian, fallopian tube, and uterine cancers.
Exactly. That's great. Great question. Thank you for bringing that to our attention. We're learning more and more about these. And we, look forward to seeing expanded results from years of experience in genetic testing. And so those may evolve over time for sure. Another great question from one of our advanced practice nurses regarding HPV vaccine and age. Any studies showing benefit to vaccinating earlier at age 9 rather than 11? I don't have the sort of original paper up in front of me, whether or not they broke those groups down like they did in the trial here, showing benefit to 26 to 35 as opposed to 35 to 45. I think really the overall thinking is to try to get this in as early as possible before any exposure to HPV. And as soon as we can do that, the better, so that we do know that those people who are enrolled in the trials of HPV vaccination, those who were HPV naive certainly had a better response at clearing that infection. And so while I don't have any data to say 9 versus 11 off the top of my head, I think as early as possible within the recommendations of the FDA and CDC. We have another great question from someone asking about the role of heated chemotherapy during surgery. That's a great question and an evolving topic. This was one of the first RCTs that we presented here tonight from one of the European groups. And we are excited to offer this on selected patients through Smilow. Who meet good criteria, who have good performance status, and who meet certain eligibility criteria. Sorry about that, everyone. And that is certainly something that should be brought up with your treating GYN oncologist in order to determine if you might be a good candidate for that type of approach. Because there is early data that signals there may be benefit for those patients who are deemed eligible for that technique. We have another great question from someone talking about the difficulty with PARP inhibitors. Any recommendations on improving patient tolerance? That's a great question. So in terms of PARP inhibitors, what I tell most of my patients is those first 4 to 6 weeks can be very challenging. And it's really the fatigue, I find the most part that patients struggle with. A bit of the nausea as well, because of the fact that this is an oral medication. Most patients do seem to get through those first 4 to 6 weeks with either, watching the anemia to ensure that fatigue is not watching the hemoglobin to make sure that the fatigue is not anemia related. But for those who don't make it through that sort of introductory first couple of months and still continue to struggle, there has been some exploration of perhaps switching from one PARP inhibitor to another. We think overall the side effects are somewhat of a class effect, but there are some very small series and experiences, and perhaps going olaparib to niraparib or vice versa. If you can get that approved based on whatever genetic profile you're dealing with in that patient. But for some reason or another, some patients just seem to tolerate one better than the other. And so, I tell most of my patients to hold out if they can, and we try to support them through those first 4 to 6 weeks. But if there's persistent, grade 3, grade 4 toxicity, you could consider perhaps switching to a different formulation. But again, that would be depending on approval and what molecular characteristics you're working with. They're great questions from everyone. I really appreciate the discussion. I think that's pretty much it for now. So again, please feel free to reach out if you have any questions regarding the material we covered tonight, or you have a question in general. We'll try to get that answered for you. And we really appreciate you joining us tonight. We're really excited about how things have evolved. I could have never imagined even, when I decided to be a GYN oncologist, that we would be talking about these advances so quickly. And we really hope that we evolve things at a pace that keeps women alive longer, enjoying a better quality of life, and until we can treat this like a chronic disease like anything else. All right, so thank you so much for everyone, and we hope to see you soon.